The meeting is streamlined. Dr. Jyoti Nara, you may please proceed.
Thank you, sir.
Dr. Naveen, sir, with your permission, should we begin the meeting, sir?
Please start.
Dr. Jyoti, please proceed.
Thank you, sir. A very good evening once again. Distinguished guests, esteemed speakers, my respected colleagues, and dear friends. On behalf of the Webinar Organizing Committee of RSACP, it is my absolute pleasure and honor to extend a hearty welcome to each and everyone who joined us today evening. The theme today is obstetric anesthesia. It is a dynamic and critical subspecialty. As anesthetists, we work as the peripartum physicians. There are unique physiological changes during pregnancy, and that makes our patients special. Every obstetric patient is a challenge. It demands meticulous planning for safe administration of anesthesia. So we have to be comprehensively updated. Today, we have designed this webinar to address this continuous learning. I invite Naveen Malhotra, National President, RSACP, President-elect ISA National, to present the welcome address. Sir, please.
Good evening, all, and I place on my record my deep sense of appreciation for RSAP Gurugram branch for conducting this webinar, and I convey my best wishes to all the speakers and chairpersons. And thank you, Dr. Shalini Mittal, for coordinating with Dr. Vishal Singla and Dr. Jyotinara, Dr. Parul, and I also see Dr. Sangeeta Khanna. So I'm very sure the topic is very, very pertinent, and under the able guidance of our chairpersons, Dr. Sangeeta Khanna, Dr. Anju Grewal, and Dr. Kiran Preet, we will have a good academic time. And thank you very much.
Thank you, Dr. Naveen.
Thank you, sir. I now request Dr. Vishal Singla, National Secretary, RSACP, to welcome everyone online.
Very good evening, ma'am. But before I say, ma'am, we have Dr. Tej K. Kaul, our patron RSACP, with us, ma'am. I would like sir to please give us blessings and say a few words, sir. Dr. Tej K. Kaul, sir, please. Sir.
Good evening, everybody.
Good evening, sir.
I welcome each and every person attending, the organizers, the co-organizers, the governing council of the RSA, who have taken all the efforts to have this webinar on obstetric anesthesia. I have in fancy in anesthesia been talking about obstetric anesthesia that there is no anesthetist who has not administered anesthesia to an obstetric patient, whether it is for delivery or for something else. But obstetric anesthesia is a very component of anesthesia in general. I am sure the speakers, under the guidance of Dr. Anju, Dr. Shali, and others, are going to give us an excellent presentation, and everyone will be, I am sure, will be enriched in their knowledge. My best wishes to the organizers, speakers, and everyone whosoever is associated with. Best wishes to everyone. Thank you.
Thank you very much, sir. And very good evening to everyone here. My regards to our patron, Dr. Tej K. Kaul, sir, Dr. Naveen Malhotra, sir, Dr. Sangeeta Khanna, ma'am, Dr. Anju Grewal, ma'am, Dr. Kiran Preet, ma'am, our esteemed chairpersons in this in this webinar, and all the speakers as well. I would like to congratulate RSACP Gurugram branch for conducting this webinar series. And also, I would like to take this opportunity to welcome you all to to Indore for RSACP Con 2026. Please mark your dates for 10th to 12th April 2026 for 34th National and 5th International Conference. It will be a great academic extravaganza plus great tourism as well. Please do join us in Indore. Now, I would like to call upon and welcome and call upon Dr. Neha Sinha, who successfully conducted RSCCP Youth Conclave 2025 of Research Society of Anesthesiology, to please tell us about the Youth Conclave 2025 and the other proceedings. Dr. Neha Sinha, please.
Thank you, Dr. Vishal, sir. Good evening, everybody. Good evening, President, RSACP National. So it gives us immense pleasure on the coordinators on the behalf of the RSACP Youth Conclave team that we have successfully culminated this program. And we have had around 60 wonderful, excellent academic presentations, including non-academic ones, which has already given us a lot of young anesthesiologists. So now the time has come where all of us have been eagerly waiting. First of all, I would like to thank Dr. Naveen Malhotra, sir, the brainchild behind this youth conclave, and for believing in us so that we could have done this very successfully. Vishal Singla, sir, thank you for your support, sir. And my coordinators, Dr. Tanveer Singh, sir, Dr. Nitin Chaudhary, sir, and Dr. Neha Mishra. So all of us, we've put in hard work. And these were the categories in which we had presentations. Almost around 60 presentations were there, which included consultants, residents, all below the age of 40 years. There was original research work, case series, case reports, academic talk, free talks, and then we had entries in wellness programs like infographics and caption it as well. So the round one winners, we had two rounds. So the winners for the round one, they have been awarded a prize money of worth 10,000 INR with certificate and a gradual advancement to the finale, plus faculty invite to the RSACP in the 2026. And the runners up, they got a chance to compete in the finale and a faculty invite to RSACP in the 2026. So now I would like to invite Dr. Naveen Malhotra, sir, to announce the results.
These results are already announced, so you can brief the House of the round one.
Right. So the round one results we had from all the sessions, total 5 sessions were conducted. Our winners were Dr. Poonam Godwal, Dr. Raghav Gupta, Dr. Ira Dhawan, Dr. Gauri Ganga Khedkar, and Dr. Abhishek Kumar. And the runners-up were Dr. Jain Roy, Dr. Pooja Behani, and Dr. Bhushanam, Dr. Tanigai, Dr. Sangamitra Sarma, and Dr. Prerna Agarwal. So the finale was conducted between these candidates. Over to you, sir, for the grand results, sir.
Right. So it gives me immense pleasure and satisfaction that with the good support of Dr. Vishal, Dr. Neha, Dr. Tanveer, Dr. Nitin, and Dr. Neha Mishra, we have successfully concluded the 2025 RSAP Youth Conclave. And the grand results are the consolation. There are 3 prizes. One is for the winner, second is for the first runners-up, and there is one consolation prize also. So the winner becomes the RSA Youth Orator 2025 with a prize money of 25,000, and the winner will deliver the youth oration during the Indore conference, and the first runners-up gets a prize money of 15,000 INR. And the consolation prize goes to Dr. Prerna Agarwal. The first runner-up is Dr. Gauri Ganga Khedkar, and the RSAP Youth Orator 2025 is Dr. Ira Dhawan. She is the winner of the finale, and the RSA Youth Orator, which carries a prize of 25,000 rupees, national oration during the Indore conference, and a certificate to Dr. Ira Dhawan. Heartiest congratulations to all the winners. But for us, all the participants and all the finalists are winners. And I look upon to Dr. Neha Sinha and Dr. Tanveer Singh for successful conduct of Youth Conclave 2026. Thank you very much.
Thank you very much, sir.
So,
Thank you very much. Thank you very much, sir, for this wonderfully concluded Youth Conclave 2025. Over to you, Dr. Jyoti, please.
Thank you, sir. It is time now to begin our academic feast. I now invite our chairpersons for the same. First and foremost, Dr. Anju Gariwal, Professor and Head, AIMS Bhatinda. Ma'am is President-elect RSACP and nominated President of AOA. It is a pleasure to have you with us, ma'am. Second, we have Dr. Sangeeta Khanna, Vice Chairperson, Medanta Institute of Critical Care and Anesthesia, an enthusiastic teacher and mentor. It is an honor to have you with us, ma'am. Last but not the least, we have Dr. Kiranpreet Kaur, HOD, Department of Anesthesia and PGIMS Rohtak. Thank you, ma'am, for being with us. Over to the chairpersons to conduct the scientific program, please.
Thank you so much, Dr. Jyoti, for the very kind introduction. A very good evening to all present here, especially our regards to Dr. Tej K. Kaul, Dr. Naveen Malhotra, Dr. Vishal Singla, and the entire team of Gurugram for organizing this excellent webinar on obstetric anesthesia. And sir, as sir rightly said, there is hardly an anesthetist who would not anesthetize a pregnant mother during their careers. So it's essential that we administer safe anesthesia to our mothers and have good outcomes. And to begin with, we will have the first speaker, Dr. Parul from Gurugram, who would be talking on labor epidural, busting the myths, separating facts from fiction. It is a pertinent topic, especially in the light of WFS's declaration that every mother should receive pain relief during her childbirth. So over to you, Dr. Parul.
Thank you, ma'am, for the introduction. And I would like to start with my talk. I hope my screen is visible.
Yes, but you can make it full screen. Yeah.
Just a minute. Okay. Is it okay?
Yeah.
So once again, good evening, everyone. So I am going to talk about a very controversial, very confusing topic, which we keep on doing every day, but at the end, we are still left with many doubts. So as far as myths and controversies are concerned, I will discuss like a lot of things in my talk, and I will try to clear the doubts as much as possible. But still we might left with some things which so am I audible?
Yes, ma'am. Yes, ma'am. Please go ahead, ma'am.
Okay. So the delivery of the infant into the arms of conscious and pain-free mother is one of the most exciting and rewarding moments in medicine, as we all know. So providing analgesia for labor has always been a challenge because of the controversies and myths surrounding the labor analgesia. Just a minute. I'm sorry, something is like wrong. I'll just figure it out. Okay. Okay. Okay, so modern neuraxial analgesia has come a long way. So there has been a pleasant upgrade in the obstetric anesthesia. So the focus has been like shifting from simple focus on pain relief to a more focus to improve the overall quality of analgesia. The International Association for the Study of Pain has declared 2007-8 as the global year against pain in women. It has said that real women, real pain. So these are some of the concerns which we will be discussing. Like, we are always doubtful regarding the timing of epidural. Will it have any effect on the duration of labor? Is it really feasible to go along with the walking epidurals? Do we need to catheterize all the patients who are opting for labor epidurals? And what about vaginal birth after cesarean? Can such patients also get epidural? Then maternal fever, fasting guidelines, breastfeeding, backache, etc. These are some of the things which I'll be discussing. So as far as timing is concerned, the ACOG and the American Society of Anesthesiologists, they have said that there is no need to wait till any particular cervical dilatation. Maternal request is sufficient and enough indication of pain relief in labor. Also, the Cochrane review has also suggested that early or late initiation of epidural for labor has similar effects on the rate of cesarean, instrumental birth, duration of labor, and neonatal outcomes. So, rather than waiting for a particular cervical dilatation when the women is in a lot of pain, the procedure also becomes technically difficult and it can be harmful. So, maternal request is sufficient to proceed with the labor epidural. So early versus late. So does it increase the risk? So clearly they have said that there is no risk of increased cesarean section if the epidural is timed early as compared to later. So coming to the second thing, which is the effect of labor epidural on the duration of labor. So there are multiple studies like RCTs, or also observational retrospective studies, where they have said there is very no or little effect on the first stage of labor. Even if in some studies it has like slightly prolonged the duration of first stage, it is clinically insignificant if mother has achieved good pain relief. But some of the studies, they have shown that there is slight prolongation of the second stage of labor. So after going through various studies, I came to the conclusion that in most of the studies there has been a mean increase of 15 to 30 minutes of second stage labor, which has not led to any adverse maternal or neonatal outcomes. And this 15 to 30 minutes duration becomes very clinically insignificant when we see the entire course of the labor. So the thing which is important here is that low concentration of local anesthetic had no effect on the duration of stage of labor. Like earlier, traditionally, very high concentration of local anesthetic like 0.25 or 0.5% bupivacaine was being used, which has led to certain problems. But since we have come a long way from that time, now low concentration local anesthetic with adjuvants, opioids, etc., they don't prolong labor. But when we go through the literature, we also find it difficult because to assess exactly assessment of the duration of labor is very difficult, because some women may present early, some may present late. In some patients, the PV examination is done later because they are pain free. In some, it is done early. So it is very difficult to assess the exact duration of the labor. So it is very difficult to say ki how much epidural or our drugs, they affect the duration. So this is the study which was published in Lancet, effect of low dose mobile versus traditional epidural. Traditional means like high doses, 0.25, 0.5% bupivacaine. Also WFSA has given this tutorial on the ambulatory neuraxial analgesia. Also, there are multiple articles showing us the benefit of ambulatory analgesia. But walking epidurals, do they really benefit anyone? I'll discuss. So this is a comparative obstetric mobile epidural trial. It showed that there was a reduced time to vaginal delivery rate with CSE and low dose infusion in nulliparous women. Maternal epidurals lead to very greater maternal satisfaction. Like, women used to be very happy. They used to be like, they had control of their labor. They were not in bed. So they were very happy. And the upright posture, it definitely favored spontaneous vaginal delivery. Because of gravity, there was decreased iotocaval compression. So this upright position is definitely physiologically better. It leads to like stronger, more coordinated contraction. So if possible, we should try to give mobile epidurals like ambulatory. But then there are other trials which have not found any difference in the mode of the delivery. They have these trials, they suggest that as long as low dose epidurals are used, whether the patient is in bed or is ambulating, the results are same. So, but if the parturient, she is ambulating during the second stage of labor, then the ambulation in the upright position definitely can have a favorable effect on the fetus, and it can affect the delivery mode. But when I was going through like different literatures, I found that not many women, they were like ready to ambulate during the second stage. Most of them wanted to rest and just be in bed. So, so when we discuss about ambulation, the safety of the ambulating mother is very important. So it has been established. We always think that proprioception is lost, she will fall, so she should not move, but it's not like so. Her balance is just as good as any pregnant woman at term. Blood pressure is also more stable because there is less iotocaval compression. Also, there is reduced need of catheterization. So she just feels like a normal labor with less pain and more benefits to mother as well as the fetus. So the most important technique which can lead to ambulatory, which can help the women to ambulate, is a combined spinal epidural with the intermittent low dose top ups. Also, we can go for low dose infusion. They provide excellent pain relief and with very negligible maternal fetal complication. So the risk of falls, yeah. So this is very important. When we opt for ambulatory anesthesia, we should always accompany the mother. Somebody should be with her. She should be continuously monitored for any postural hypotension, for any hypotension from the effect of epidural. They should be actively monitored, and if everything is fine, then only they should be allowed to move. But there are studies where women in labor with and without epidural, they were compared. So there was no differences in balance measured with posturography. So I would like to say that if we start practicing more mobile labor epidurals, more and more patients will start loving us for that. So now the effect of epidural on the instrumental vaginal delivery. So there is a lot of earlier literature which has suggested very high increase in the instrumental delivery with labor epidural. And still the data is very controversial. And as we all know that our modern obstetric colleagues, they are not that much into instrumental vaginal delivery nowadays. So anything which can lead to increased chances of instrumental delivery will in turn lead to second stage cesarean. So also I found one more thing while going through the literature, that because of epidural, there was like the perineum and pelvis were like so relaxed that the obstetrician, they opted for instrumental delivery in those patients. Like even if they had like, even if they could manage without it, but they, for teaching purposes and for all those purposes, instrumental deliveries were more in women with epidurals. But with our present day low dose epidural, the chances are very less. So the effect of epidural on cesarean rate. So almost all the literature which is coming up nowadays, in past, like in the past decade, they all of them show that labor analgesia does not increase the chances of cesarean. And it must be always kept in our mind कि cesarean, just epidural is not the cause for a cesarean. The chances of cesarean depend upon many factors. So women who have more pain and they require more analgesia, they are at definitely increased rate of cesarean delivery, not because of the epidural, but because of the other fetal and maternal indication. They also demand epidural early. So in that case, the early epidural does not lead to increased chances of cesarean. Effect on fetus. So there is a lot of data and lot of studies which has been done to clear out this point, and they have come to the conclusion that combined spinal epidural, which uses intrathecal opioid with a low dose bupivacaine, has been associated with fetal heart abnormalities. But there is increased risk of fetal bradycardia, but there is no increase in the pathological fetal heart tracing as assessed by the Apgar scores, or umbilical artery and vein pH, or base excess, or the obstetric outcome. So if after the epidural we are monitoring the fetal heart and we are monitoring the mother for any hypotension, labor epidural is not associated with any negative neonatal outcomes or increased cesarean for fetal distress. Now coming to another important point, which is like early pushing or late pushing during the second stage. So this is a people's study which showed that the rate of the spontaneous vaginal delivery was higher, the duration of pushing was shorter, rate of forceps delivery was less when the woman was randomized to delayed pushing compared to the immediate pushing. It appears that the delayed pushing does not impart any major neonatal or maternal benefit, although it seems reasonable to delay pushing until the fetus has descended to a lower station to avoid maternal exhaustion, because there is no point in forcing the mother to push when the baby is high up. So passive descent should be encouraged along with delayed and monitoring to safely and effectively increase spontaneous vaginal births. Also, decrease instrumental deliveries, and there was also less of pushing time when the mother was encouraged to push later. So this is practice nowadays also, like I myself has seen in many centers, like anesthetists as well as obstetricians, they discontinue the epidural during the later second stage. But does this epidural really needs to be stopped? So many studies, they have studies this thing that discontinuing epidural does not have any beneficial effect on the maternal or fetal outcomes. Rather, it leads to a lot of pain and maternal dissatisfaction. So, and latest literature shows no such increase in the instrumental vaginal deliveries or the cesarean deliveries. So this is the Cochrane review, which shows that discontinuing has no adverse benefits. Coming to the combined spinal epidural analgesia. So CSE is now worldwide accepted for labor analgesia. Intrathecal opioids plus low dose bupivacaine, like less than 2.5 mg, plus low dose bupivacaine plus vaginal infusion or boluses can be done. Because of the intrathecal drug, it has a faster onset, it has a reduced local anesthetic consumption and better sacral spread due to dural puncture. But then there are some inherent problems which are self-limitary, like pruritus. Pruritus, there is sudden decrease in the fetal heart rate, which improves with intrauterine resuscitation, like giving fluids, changing mother's position. And also, when spinal is given, then the testing of the epidural catheter becomes a little difficult till the effect of the spinal stays. So, causes of this transient fetal bradycardia. So, let us understand what causes this transient bradycardia and how can we manage it. So, rapid onset of analgesia due to intrathecal drugs, they lead to imbalance in the catecholamines like ADR and nor-ADR, they decreases, which leads to uterine hypertonic. Also, hypotension can be there because of the intrathecal drugs, and iotocaval compression, as we all know, is there. So a wedge can be kept. And also oxytocin independently increase the likelihood of the fetal heart rate abnormalities when it was given in combination with neuraxial analgesia. So in utero fetal resuscitation is like most of the time successful in restoring the fetal heart rate. Like we can change the maternal position, we can give a fluid bolus, we can stop the exogenous oxytocin, and also patient should be monitored like for 15-30 minutes, should be very closely monitored for any maternal or fetal complication. So the next thing is programmed intermittent epidural bolus versus continuous epidural infusion. So programmed epidural boluses, like many places they have started using it, and it has led to a decrease in the total local anesthetic use, decreased doses, decreased motor block, and also improvement in the analgesia. There has been significant decrease in the breakthrough pain with programmed intermittent boluses. But higher concentration of higher volume of low concentration local anesthetic is necessary. So as far as PIEBs are concerned, their volume and time interval is very important in determining analgesia than the total hourly dose which has been given. So after going through a lot of regimes, I found out that the drug volume of about 10 to 12 ml of 0.1% bupivacaine with 2 mics per ml of fentanyl can be given intermittently at an interval of about 40 to 45 minutes. So when this was given at an interval of 60 minutes, then there was like more breakthrough pain. So after reducing the interval to 40 to 45 minutes with this much drug, showed better results. So why programmed intermittent boluses are beneficial? Because they inject the drug through a higher pressure, which leads to better spread of the drug in the epidural space. Also, the catheters which we are using, they are multi-orifice. So when we give a bolus, the drug exits through all the orifices, leading to a better spread, as opposed to solutions which are injected as infusion, which can only exit through the proximal orifice. Coming to patient-controlled epidural analgesia, it is also a novel method of the drug delivery system. Advantages: reduced drug dosage, less motor block. Patients, they feel more self-reliant. They have better self-control, self-esteem, and it has shown to have a positive experience in childbirth. So coming to VBAC, vaginal birth after cesarean. So most of the people do not prefer to give epidurals to patients who have undergone a prior cesarean, but this is not at all true. Patients should be offered, each and every patient deserves epidural or pain relief, which should be offered to her. So ASA and the Society of Obstetric Anesthesiologists and Perinatologists, they recommend offering neuraxial techniques to such patients. And also in such patients, it is advised to consider early placement of the epidural, which can be used for epidural or if required for the operative delivery as well. There is controversies regarding that labor epidural has an effect on breastfeeding. It leads to difficulty in initiating and maintaining the breastfeedings, like for 1 or 2 months postpartum. But when we go through the literature, there is no such correlation. Several studies and trials, they fail to demonstrate a significant association between epidural and lactation failure. And to further assess this, we might need few more studies to see exactly the strength and association, if any. Most of the women during their antenatal visits, they have that if I'll take an epidural, I will have a back pain forever. So no, multiple studies, RCTs, they have proved that there is no significant differences in the incidence in terms of back pain between women who received epidural and those who received other form of analgesia. So epidural related maternal fever. Yes, epidural has led to slight increase in the body temperature of patients, which is under investigation. So observational and randomized studies, they demonstrate that epidural is lead to increase in the maternal temperature, which has led to increase in the neonatal sepsis workup. So the exact cause of this fever is not known. It is mostly non-infectious, and in the placenta sample, some inflammation of the placenta was found. So it is inflammatory, and temperature rises never above 1 degree with epidural as compared to their baseline temperature. So if there is a temperature rise of more than 1 degree, then definitely needs further workup. And if it is within this range, then no need for neonatal sepsis workup is required. And what is the cause? The prolonged labor can lead to this risk of increased temperature. There is increased shivering, decreased heat loss, and some temperature regulation can be altered due to the epidural. As far as NPO is concerned, the current ASA guidelines say that all the laboring patients should be allowed clear liquids in definitely uncomplicated labors, and there should be complete avoidance of the particulate and solid food. So avoiding high dose local anesthetic test dose reduces motor block. Yeah, so this is very important. There is no role of a test dose in a labor epidural. See, because first of all, the 2% dignocaine which we will give, it will lead to motor block. And secondly, already the mother is having lot of tachycardia, so it will be very difficult to assess the effect of the test dose. So as far as labor epidurals are concerned, each and every bolus should be treated as a test dose. And we should always focus on reducing the dose without compromising the analgesic efficacy. So it will always increase our margin of safety, and it will also help us in fine tuning our epidural. And good labor epidural leads to better maternal satisfaction, and with improved techniques, there is like less to negligible feto-maternal complication. So there is no single universal method of managing labor pain which fits all the patients and all the situation. Multiple obstetric and anesthetic factors, they exist, which require individual tailoring, and ultimately it is each anesthetist's responsibility to take these factors in mind in order to provide a safe and effective labor analgesia for each of our patients. So an epidural for pain relief is really a great method. It does not define birth. It is not the easy way out. It is completely right for like some people, except for those who have other contraindication. It is totally a mother's choice, and it is definitely not a failure to cope. So there is a myth that getting an epidural is failing at natural childbirth, but in reality, we don't give out awards based on how moms give birth. Thank you.
Thank you so much, Dr. Parul. I think I'll hand over the mic to Dr. Sangeeta Khanna to introduce this next speaker. We can have the questions at the end of the session. Thank you. Thank you. It's an excellent talk.
Thank you.
Thank you, Parul. I think well covered, all the points, important points have been covered. And we all know this is a challenge that we face for all the patients who come to us for an epidural. A lot of questions that get asked. I think you have answered all of them. So let's go on to our next topic, which is again a very important topic on PIH. I think all of us have seen patients with PIH, and over the years, the definition, the management, everything has changed and is still undergoing a lot of change. So for that, I'd like to invite Dr. Kirti Kothari, who's a consultant in Meringo Asia Hospital, and who's going to give us on the latest advances and developments in PIH. So over to Dr. Kirti.
Good evening, all the respected seniors, colleagues and friends. I'm Dr. Kriti Kothari, consultant anesthesiologist, Meringo Asia Hospital. And today I'll be talking on updates on anesthesia in PIH. So why are we discussing it today? Is to describe the diagnostic criteria for hypertension and preeclampsia and identify the risk factors mainly so that we can timely diagnose and treat, apply risk prediction models for preeclampsia and clinical practice, and formulate the management plans for women to manage timely. Now, as latest as 2025, the International Society for Study of Hypertension in Pregnancy has updated the definitions of the spectrum of hypertensive disorders of pregnancy. First one is chronic hypertension, which describes hypertension which is present prior to the pregnancy, that is before 20 weeks of gestation. White coat hypertension, in which the blood pressure is more than 140/90 in the clinic, in the doctor's clinic, but not at home. It is less than 135/85 at home. Masked hypertension is less than 140/90 at clinic, but more than 135/85 at home. And finally, the gestational hypertension, characterized by new onset hypertension, in which the systolic BP is more than 140 and diastolic is more than 90 after 20 weeks of gestation. Pregnancy-induced hypertension. It is the most common disorder of pregnancy, which we encounter almost every day, all of us. And it's a broader term for higher blood pressure in pregnancy, while preeclampsia being the more serious one. So PIH refers to 4 conditions: pre-existing hypertension, gestational hypertension, and preeclampsia. Pre-existing hypertension plus the superimposed gestational hypertension and the unclassifiable hypertension. Of course, we should not forget to mention eclampsia here, which is the most severe form of PIH, but we won't be discussing it here. We'll be mainly focusing on preeclampsia. Preeclampsia is a multi-system disorder associated with end organ damage that forms part of the spectrum of hypertensive disorders of pregnancy. I'm using again hypertensive disorders of pregnancy word because latest literature shows that this term is being used more often now rather than PIH. It occurs after 20 weeks of gestation and contributes to significant maternal and fetal morbidity. Due to potentially rapid progressive nature, it progresses very rapidly, so we cannot divide it into mild, moderate, and severe. So those terms have become obsolete, and now we are dividing it on the basis of whether the preeclampsia is associated with severe features or not associated with severe features. Superimpose preeclampsia on chronic hypertension, which has associated lack, pulmonary edema.
Dr. Kirti, you're not be audible. I think the signal has been lost. Network में problem है.
Visual disturbances and new onset headache, which is unresponsive to the sorry. Late onset preeclampsia is more common in nulliparous younger mothers.
And you need to share your screen.
You need to share your screen. Yeah.
Okay, sorry.
I think if your signal is poor, you can switch off your video and share the screen.
Okay, ma'am. 1 minute. I'm unable to do it. So no. Just a second, ma'am. I'll do it again. Again, to share.
Please re-log in and perhaps you'll be able to do it.
Sure. Ma'am, is it visible now?
Yes, yes.
Yes,
Just full screen kar lo. And maybe you'll have to go back 1 or 2 slides.
Yes, ma'am. Sorry, ma'am, for the disturbance.
It's okay now.
One more back, one slide back. Yes.
On this only, sir.
Yeah.
Early onset preeclampsia.
You may please switch off your video if your
Onset
bandwidth is
early
poor.
onset is before 30.
You may please switch off
No,
your
sir,
video
it's
if your
okay.
bandwidth is
It's
poor.
okay.
Okay, please go ahead.
Okay. And late onset preeclampsia, which is after 34 weeks. Coming on to
Dr. Kirti, there is problem with your network, I
the
think.
pathophysiology of preeclampsia is complex development, maternal immune response, and endothelium balances the pro-inflammatory.
Dr. Anju, Dr. Kirti has some problem with the internet.
Yes, sir.
In between, it is there.
So
in between,
perhaps
it is
till the
gone.
time, yeah, if Kirti, you're having major issues with
Ma'am,
your
1 minute, ma'am. I'll just
we can wait and you can come back again. We can have the third speaker to go in.
video off. Video. Ma'am, is it okay now?
Yes, it is okay now.
It is okay. Please go ahead.
Off.
आपके अगर मल्टीपल डिवाइसेस हैं सेम इंटरनेट पे उनको भी डिस्कनेक्ट कर कभी कभी इसलिए भी बैंडविड्थ कम हो जाती है.
Yes, ma'am. The salient features about the preeclampsia, it affects 2 to 8% of all the pregnancies and is associated with significant maternal perinatal morbidity and mortality. 2% of all the deaths have been reported between 20 to 22 in UK due to HDP. And maternal deaths usually occur due to stroke, pulmonary edema, and renal and hepatic failure. PIH is also responsible for postpartum hemorrhage, placental abruption, coagulopathy, significant neurological maternal morbidity. and it remains one of the leading causes of fetal growth restriction, preterm birth, and stillbirth. Now, coming on to the main features, preeclampsia is associated with the main features like proteinuria, which is 1+ or more on the urine dipstick, which is classified as urine protein or to creatinine ratio of more than 30, and albumin creatinine ratio of more than 8, uteroplacental dysfunction, which includes the restricted fetal growth and abnormal umbilical artery Doppler waveform, hematological dysfunction, and maternal organ dysfunction, which is neurological, pulmonary, renal, hematological, and hepatic. Now, the risk factors for development of preeclampsia. There are several risk factors which are classified as major and moderate as per the NICE guidelines, which shows the women are at increased risk of developing preeclampsia. And to label women as screen positive, the women should have one major factor and any two moderate factors positive. Major factors include HDP during the previous pregnancy, chronic maternal BMI more than 30, diabetes mellitus, autoimmune diseases like APLAS, SLE, chronic kidney disease. And moderate risk factors, nulliparity or pregnancy interval more than 10 years, advanced maternal age more than 40, family history of preeclampsia, multi-fetal pregnancy or BMI more than 35. NICE guidelines have given prevention measure for preeclampsia PIH, that in high-risk patients, the obstetrician should start low-dose aspirin 75 to 150 milligram as early as before 12 weeks of gestation. If we recommend later after 14 weeks, it has of no use. So it is recommended to prescribe before 12 weeks to all the women who are at high risk for preeclampsia. Coming on to diagnosis, on how we can diagnose, there are two factors, soluble FMS tyrosine kinase and placental growth factors, which are important in the pathology of preeclampsia. Soluble tyrosine kinase, it increases in preeclampsia, it leads to vasoconstriction and it leads to endothelial dysfunction. And placental growth factor, which normally increases in pregnancy, during the time of 20 to 36 weeks, but it decreases in preeclampsia. So its ratio is used to diagnose preeclampsia. If it is less than 38, then the woman has no risk. If it is between 38 to 85, that is not definitive diagnosis, but yes, of course, women need follow-up. And if it is more than 85, it is highly suggestive of preeclampsia, and the patients should be monitored regularly, should be started on the preventive measures and intense monitoring. Although this test is not available in all the labs and it takes around 1 to 2 days for the result to come out. So still the clinical assessment and proteinuria, all these things are majorly used to diagnose and start the treatment. Coming on to the preoperative assessment and planning. It needs a comprehensive teamwork, which involves all the specialists, pulmonary hypertension specialists, the obstetricians, cardiovascular anesthesiologists to manage the PIH. Also, early hospitalization and close monitoring. Once the fetus is viable, it's recommended for patients with severe pulmonary hypertension. Antenatal airway assessment is very, very important because as it is physiological changes in pregnancy, it complicates our airway, leading to subglottic edema and all those things, which makes our intubation very, very difficult. Elective cesarean surgery should be considered for patients with severe pulmonary hypertension. There's no need to give any trial for labor, normal delivery in these patients who are already in severe category. Airway evaluation, hemodynamic status, and coagulation profile, they are the main standards which we use for the assessment. Hemodynamic status, hypertension is generally the earliest clinical finding in preeclampsia and should be treated in the peripartum period with oral or IV medicines like nifedipine, labetalol, hydralazine, and we should always monitor coagulation profile in patients with severe preeclampsia or HELLP syndrome. We have to see the platelet count. If they can develop thrombocytopenia, and if we plan for neuraxial anesthesia, it can lead to spinal epidural hematoma. And neuraxial for platelet count is also required for our neuraxial anesthesia, and neuraxial anesthesia is safe only in the patients who have platelet count more than 70,000. Also, there are queries regarding whether we should stop aspirin or we should continue aspirin for the neuraxial anesthesia. But papers have suggested that low dose aspirin has no effect on our neuraxial anesthesia. Coming on to the hemodynamic monitoring, invasive hemodynamic monitoring, including pulmonary artery catheterization, are recommended for severe PIH patients. Central venous monitoring is also valuable in assessing the intravascular volume status, and continuous monitoring of arterial blood pressure, ECG, and oxygen saturation. Now coming on to what should be our goal blood pressure. In pre-eclamptic patients, aims to keep the patient BP closer to the baseline. Obviously not less, but always it should be not more than 160 by 110. It should always be less than 160 by 110 and close to the patient's baseline BP. Blood pressure more than 160 to 100 by 10 should be aggressively lowered while monitoring the fetus to be sure that uteroplacental perfusion is maintained and late decelerations do not develop. And we should also avoid severe hypertension to reduce the risk of stroke and ICH. Avoidance of hypertension is also very necessary to maintain the uteroplacental perfusion. Intravenous fluid management. Peripartum fluid management should be monitored closely. In the patients with severe eclampsia, it should be restricted to 80 to 100 ml per hour. Also, which includes all the infusions which we give, like oxytocin, magnesium, etc. Restrictive volume of fluid should be administered during the initiation of neuraxial labor analgesia and also during the cesarean delivery. In most of the patients who receive low-dose local anesthesia, there is no need to give extra fluid to prevent hypotension. The neuraxial anesthesia being the choice today also and before also, low-dose combined anesthesia, spinal epidural anesthesia has emerged the preferred approach for C-section patients in PIH, allowing for careful titration of anesthetic agents, which minimizes the hemodynamic instability. Epidural anesthesia with slow incremental administration of local anesthesia can be safe for both mother and fetus. And continued epidural anesthesia has shown great outcomes for cesarean deliveries, and mostly in the patients with idiopathic pulmonary hypertension. The most important advantage is it avoids severe hypertension, which we see mostly in general anesthesia or in other cases that the BP, we are not able to maintain BP as much as the neuraxial anesthesia maintains it. It avoids the need of endotracheal intubation also, and avoids the need to give the neuromuscular blockers because it interacts with the magnesium sulfate, which is given for the treatment of preeclampsia to avoid seizures. And magnesium is shown to increase the effect or the delayed recovery from the neuromuscular blocking agents. And it may also lead to more hypotension, which can affect the neonatal outcome. In general anesthesia, in case we have to give in case of emergency, then general anesthesia requires careful attention, especially in the part of intubation when need to attenuate the hypertensive response. We can use fentanyl to effectively blunt the hypertensive response, and succinylcholine and atracurium with nitrous and isoflurane have been successfully used for general anesthesia and PIH patients. We can use labetalol boluses, propofol, succinylcholine, and NTG boluses and infusion nicardipine to initially blunt the systolic blood pressure. Sympathetic response can also be controlled with remifentanil very, very effectively. It crosses the placenta, but it has it also shown, the papers have shown the transient change in transient depression in the respiratory efforts of neonate, but not long-term changes. Maxulf, I've already told that it potentiates the effects of neuromuscular blockers, so they should be carefully used with the Maxulf. Cautious fluid management is critical for the perioperative management. Fresh frozen plasma should be kept ready to correct coagulopathy in case there is HELLP syndrome associated. Platelet transfusion should also be considered when platelet counts are below 50,000, and hydrolysine infusion can be used to control blood pressure and reduce the risk of eclampsia and intracranial hemorrhage. Coming on to the post-op care, high dependency monitoring for at least 24 hours. We cannot be relaxed that if the baby is delivered now, there is no risk of any eclampsia in the PIH patient. We have to do continuous monitoring for 24 hours. And if available, we should do continuous invasive monitoring for arterial blood pressure and CVP, and also urine output is very, very critical to monitor. Multimodal analgesia can be used. Paracetamol, NSAIDs, dexamethasone in post-cesarean patients. Intrathecal morphine and diamorphine also have provide effective post-operative analgesia as part of neuraxial anesthesia. The special considerations are, despite modern treatment approaches, still the maternal mortality remains very high in severe pulmonary hypertension patients. Pregnancy should be discouraged in the patients who already have hypertension and very severe pulmonary hypertension. Immediate postpartum periods is the most dangerous. We should not relax ourselves and keep the patient in continuous monitoring. And hemodynamic changes are associated with pregnancy and may persist up to 6 weeks after delivery. Common pitfalls and caveats, as I've already mentioned, we should avoid hypovolemia. There should be rapid hemodynamic changes during induction, which can lead to cardiovascular collapse. So we have to be very, very careful. Failure to recognize HELP syndrome can lead to inadequate preparation for potential coagulation abnormalities. And underestimating the need of invasive monitoring can also result in suboptimal management of hemodynamic instability. Thank you so much.
Thank you, Dr. Kriti, for that presentation. I think
Thank you so much, ma'am.
We'll have the questions at the end. So Dr. Kiranpreet can introduce our next speaker.
Good evening to you all and welcome to today's RSA webinar. Now we have reached the final session today of the day. And as you are all aware that nowadays we are, with the advent of the newer spinals, fine needles, the incidence of the PDPH is decreasing. But however, still we encounter off and on such kind of incidences. Every anesthesia provider should be aware of the presentation and be equipped with the knowledge for the proper and timely management. Now I'll introduce Dr. Hemant. He's a senior anesthesiologist at Manipal Hospital, and he'll be presenting his presentation on the PDPH. Over to Dr. Hemant, please.
Thank you, ma'am. Good evening, everyone. Am I audible?
Yes, you're audible.
Okay. So as ma'am said, PDPH is actually a rare but a dreaded complication of a spinal or accidental arachnoid puncture, I'll say. So what exactly is PDPH? According to the International Headache Society, they define it as a headache which happens within 5 days of a lumbar puncture caused by a CSF leak. Um, Primarily presenting as a postural headache, which worsens on sitting or standing up position and improves when the patient is lying down, may have a presentation, primarily it is frontal or occipital, as associated with nausea, vomiting, or neck stiffness. So what basically happens is after the dural puncture, it leads to a loss of the CSF volume, causing intracranial hypotension. It causes the brain to sag, causing the traction on the pain sensitive structures, resulting in the traction and causing the pain. Also, uh, there is an increase in the cerebral blood flow. The cerebral vasodilatation happens in order to compensate for the loss of the CSF volume. So what is our current treatment? So current treatment, primarily what we focus on is our conservative management, which is primarily a symptomatic relief and encouraging a CSF production. So basically we ask the patient to lie down flat, which is traditionally recommended, but its efficacy is not as strongly supported. Hydration by oral and IV fluids, which technically may lead to the CSF production, but again the evidence is not strongly supported. The Pharmacological treatment includes caffeine, which is a vasoconstrictor, counteracting the cerebral vasodilatation. which may reduce the headache, but again, the evidences are not strongly supporting it. The routine analgesics that we use, paracetamol, NSAIDs, they are usually insufficient to break the pain cycle and provide pain relief to the patient. Newer medicines like ACTH and analogs, cosyntropin, hydrocortisone, triptans have been tried, and to some extent they are able to relieve the pain, but still no solid evidence is present. So the gold standard for the treatment is epidural blood patch. Basically, 15 to 20 ml of the patient's own blood is taken autologously, injected into the epidural space where the puncture happened, preferably at the level where the puncture happened or one level up or below that. Basically, it forms a clot at the point where the CSF is leaking, thereby restoring the intracranial pressure. So this causes the cephalad displacement of CSF, increasing the pressure in the CSF, thereby reducing the traction on the pain-sensitive structures. Usually, we do it for a severe persistent PDPH not responding to the conservative management. Recent ASA studies have published that the one single shot of epidural blood patch may gives a complete relief in around one third of the patients, with partial relief in 50 to 80% of patients who may again require another epidural blood patch. So the problems, the risks, it is again an invasive procedure. It requires a sterile environment. It requires a skilled practitioner to be done. Usually requires two anesthetists, one who would collect the blood, one who would inject at the epidural space. Risks, they may require multiple epidural blood patches to be done. Procedure related, another dural puncture can happen by when we are injecting in, we are trying for the epidural space. Infections, bleedings, nerve injuries, though transient, can occur. Post-operative can be a backache or a transient radicular pain, and it may not be a readily option in patients who are already having some kind of infection or coagulopathy, or maybe the patient is on any blood thinner after the procedure. So why do we need a newer approach? Basically, patient usually what we usually encounter is that a patient who has had a headache after a dural puncture, accidental dural puncture. Basically, for the patient, the spinal and epidural would be a very similar procedure. So patient may be hesitant for another procedure involving the same risks as to the one which caused his symptoms, the invasiveness of course. And basically it so what we require is something in between the two. This is where the primary blocks they come in. They target the specific cranial nerves, thereby reducing the symptoms, giving the time to the IV or the oral analgesics and the hydration and the conservative management to occur. Basically, what we want to do is break a pain cycle. So the recent blocks that are being used are sphenopalatine block, greater occipital nerve blocks, or lesser occipital nerve block. So moving further, the mechanism is primarily the core principle of PDPH, as I said, is CSF leakage and a compensatory cerebral vasodilatation that occurs. So these nerve blocks, they aim to interrupt the pain signals uh, transmitted to the sensory nervous system, decrease the cerebral vasodilatation by blocking the parasympathetic signals. They help in effectively breaking this pain cycle and provide a symptomatic rapid relief while giving time to the dura to naturally heal. So coming to this phenylpalatine block, it is a minimally invasive block. Uh, Sphenopalatine ganglion is a crucial relay center for the cranial nerves and linked to the trigeminal system, heavily involved in the headache physiology. This block is already being used for the treatment of migraines and cluster headaches, depending upon the patient's symptoms. Um, so the it is present in the pterygopalatine fossa deep to the posterior in the deep space posterior to the middle terminate and the maxillary sinus. How do we perform it? We ask the patient to lie down with neck slightly extended. Uh, the easiest method is putting a local anesthetic via a cotton tip applicator using any of the local anesthetics which are available with us, like 2% lignocaine or 0.5% bupivacaine. What it primarily does is block the sympathetic efferent pathways to this sphenopalatine ganglion responsible for this vasodilatation. Inhibiting this vasodilatation causes the reduction of the traction on pain structures, providing rapid headache relief. So what we do is we use a cotton tip applicator, pass it parallel to the nasal cavity inside the nostril till we get a slight resistance, and we leave the cotton tip applicator at that point for 3 to 5 minutes, uh, soaked in any of the local anesthetics. So the clinical evidence shows that using of a sphenopalatine block reduces the symptoms. A single sphenopalatine ganglion block reduces the symptoms in almost 60% of the patients without requiring further intervention, invasive intervention. It provides a rapid pain relief, often within 5 to 10 minutes, or with an NRS with a numerical rating scale of less than 4 at 1 hour post the procedure. It drastically reduces the need for epidural blood patch. It is a safe and easy procedure which can be done at bedside or in the OPD with minimal complications. So, what are the routine complications that can happen? Patient may have a bitter taste or numbness and the or lightheadedness at the local area, may have bleeding, infection, hematoma chances, but they are very less, and slight nerve damage, which is transient, that can happen. So, coming to the greater occipital nerve block. Greater occipital nerve is the nerve which provides the sensation to the posterior scalp and back, basically the occipital area, and the neck. Uh, Patients usually with PDPH, they often have severe neck stiffness and occipital pain due to the muscle tension and referred pain from the meninges. Uh, the greater occipital nerve block, along with the lesser occipital nerve block, which I'll come to the in the next slide, they directly address the this component of the PDPH. So the procedure, the patient is made to lie down in a prone position with the head slightly flexed, or in the sitting position with the head slightly flexed. This is again can be done easily in as an OPD procedure or a bedside procedure with minimal in so the greater occipital nerve, basically what we do is we will palpate for the external occipital protuberance and the mastoid process, and the medial one third of that, the line connecting between the two is the point of the greater occipital nerve, where we inject 1 to 2 ml of a local anesthetic, usually 2% lignocaine, uh, and hit the eperiosteum, withdraw the needle slightly, and inject around 1 to 2 ml of the local anesthetic. The pain usually improves with this after 20 to 30 minutes of administration, and it lasts for about 4 to 6 hours. It is a direct nerve block interrupting the pain signals from the posterior scalp and neck. Uh, the recent studies have shown around 60 to 85% improvement in the headache after performing a greater occipital nerve block. Effective in relieving the primarily the occipital area pain and the neck stiffness associated with PDPH. Coming to the lesser occipital nerve block, it is again performed in a very similar way as to the greater occipital nerve block. But in this place, instead of the medial one third, we target the lateral one third aspect, where the lesser occipital nerve goes from. So this basically helps in the neck stiffness in the lateral aspect of the neck, posterior lateral aspect of the neck. Um, the combination of these blocks have been used in to provide symptomatic relief from PDPH, and helping us with the giving us time for the conservative treatment and the IV analgesics to help out with the block with the symptomatic relief till the time Uh, So this is a systematic review of a few studies which were done, and most of these studies they used 2% lignocaine via a cotton tip applicator or using a sphenocath. The numerical rating scale at 1 hour of application of these blocks was less than 4 in 18 of the 19 studies. The numerical rating scale at 24 hours was in 17 of the 19 was less than 4, and at 48 hours all studies showed a numerical rating scale of less than 4. Of course, they all used the conservative NSAIDs and IV hydration along with the application of these blocks. So, what is basically prevention of the PDPH is the best thing that we can do. What we can do for the preventing the PDPH, the key preventive measures are the using a smaller gauge needle and the pencil point atraumatic needles, which reduce the chances of a PDPH to almost 0.8%. The bevel orientation, if we are using a cutting needle, then we should place the bevel parallel to the dural fibers instead of perpendicular so as to separate the fibers rather than to pierce through the fibers. And some recent studies have shown that a stellate reinsertion uh, before withdrawing the needle is quite useful. And basically helps the arachnoid from not being avulsed. So what we require for the management of a PDPH is actually not a single shot approach, but a tiered approach that we can have. If the patient presents to us with a pain, initially we can start with the conservative treatments depending upon the patient's numerical rating scale, how severe the pain is. The next step up, or if the patient is having a severe pain, directly not going for an epidural blood patch. If patient symptoms are manageable, we can go in for these blocks if the patients agree, and they provide a rapid pain relief and giving us time for the conservative treatments to occur. If yes, in cases of severe failed blocks, of course, epidural blood patch still is the gold standard of the treatment. However, depending upon the patient and the patient's profile, we can always see for the how we want to proceed with the post-dural puncture headache. So in conclusion, the management of PDPH is evolving from a single invasive solution to a more sophisticated tiers approach. Prevention remains the paramount through improved needle technology and improved way of administrating and taking care of avoiding accidental dural punctures. Primary nerve blocks like sphenopalatine ganglion block and greater occipital nerve block, they are effective, less invasive alternatives to a epidural blood patch with good outcomes. Newer pharmacological agents are being tried and tested, and some studies are definitively required for their effectiveness to be proven, and a multimodal patient-centric strategy is the future of a PDPH management. Thank you.
Thank you, Dr. Hemant, for a nice presentation. Uh, though you have enumerated the recent blocks which we have been using, but I think these are only the temporary relief, and you have to switch on the symptomatic relief that is more important. And it is self-limiting, I think, and patient symptom may resolve within 5 to 7 days, probably within even less than that. And main focus should be on, I think, fluid therapy and hydration of the patient, position of the patient, and a good analgesic. Caffeine can be added. And I think people, they have tried ACTH, sumatriptan, many other drug therapies also. Thank you anyway. It was a good, knowledgeable presentation. Thank you. Over
Thank
to the questions, please, ma'am.
Can you stop sharing? Yeah. Thank you so much.
Dr. Jyoti.
Thank you
There
to the speakers.
Mhm.
We had our myths tested by pearls of wisdom on labor epidurals. We had a comprehensive update on PIH management and we are happy with the take-home messages on PDPH prevention rather than treatment. I now invite Dr. Shally ma'am. She is head of the Department of Anesthesia at Artemis Hospital to deliver the word of thanks, please.
Good evening, everyone. On behalf of organizing committee, I would like to thank the people who made this webinar happen. First and foremost, my warm regards to Dr. Kaul sir, and a big thanks to President Dr. Naveen Malhotra and Secretary Dr. Vishal Singla for their constant support and guidance for all the academic activities of our society. My sincere thanks to three chairpersons, Dr. Anju Garewal ma'am, Dr. Sangeeta ma'am, and Dr. Kiran Preet Kaur. It was really nice. You led the academic sessions very well, and you gave very valuable inputs regarding all these three topics. A huge round of applause for all the three speakers. Their talks were clear, structured, practical, and I'm sure it will be truly helpful for the audience. Last but not the least, my heartfelt a big thanks to Dr. Jyoti Nara. Actually, she is the one who has organized this whole webinar, and all the efforts have been put by her. Thank you, Dr. Jyoti, for that. And my warm thank you for all the audience who joined today evening. Your presence and attention definitely is helpful for these academic sessions going on. So thank you so much, everyone, and have a very good evening. Any questions regarding these topics or some kind of discussions?
Okay, if I just wanted to have, to Dr. Kriti. I mean, she talked about those tests, the placental growth factor and the tyrosine, which is being done. Is it
Yes,
indicated?
ma'am.
Yeah. So which week do you think it needs to be done? And do you think that it should be done in just, high risk group of patients, or, just patients after 20 weeks who have an increase in blood pressure, it's adequate in them? What do you think?
Ma'am, it is generally advised between 20 to 34 weeks of gestation age, and especially in patients who have high risk factors for the preeclampsia, in which the the uterine Doppler is showing abnormality mainly, and also the risk factors are present for the preeclampsia.
Okay, so it's not like a predictive thing.
Ma'am, but sorry.
I mean, before 20 weeks, that means if it will not be of much use. It's not going to be a predictive.
Ma'am, generally, yes, ma'am. Ma'am, generally the rise in this titer for normally the placental growth factor increases during this period only. So the decrease can be, monitored in this during.
Okay. And the other thing is, you mentioned the role of the pulmonary artery catheter and CVP. I just wanted to know, it's a question to all. In how many patients is actually, we use the pulmonary artery catheter or CVP in patients with...
We commonly don't use it, but it's mentioned in the literature to use it. But we generally used in severe cases, arterial monitoring and CVP monitoring for sure.
And
So
Dr.
pulmonary
like
artery,
to add? Yeah.
I just wanted to add that pulmonary artery catheter is not indicated for these mothers. All that we need is an intra-arterial BP monitoring. What is very pertinent, and I really wanted to make a comment here for this talk on preeclampsia, is that you talked about having platelet counts. It is important to observe the trend of platelet counts, and you have to remember that the platelet count may drop every 6 hourly. So ideally, in a good setup, we must insist on having serial platelet counts, and that's extremely important. I had one of my postgraduates, I do not know whether she joined or not, but she kind of faced difficulties in convincing her obstetric colleagues to have a serial platelet count for these mothers, especially when you are planning to do labor analgesia for them. So that's extremely important to remember that.
Okay, ma'am. Thank you, ma'am.
अच्छा वो क्या हुआ आज
Another question, I mean, is just to everybody, is there any role of or use of neostigmine in patients who have PDPH? Because there is literature which says that low dose of neostigmine is also known to increase the CSF secretion and improve the vascular tone. So I just wanted to know if anybody has experience with the use of neostigmine with atropine for treatment of PDPH.
Not exactly, ma'am. And I think I have posted the article of which Dr. Vishal Uppal, the consensus guidelines on the management of post-dural puncture headache. So all of these modalities are either temporary or in still investigative phases. So I believe in, especially in parturients where you have had an accidental dural puncture during putting an epidural, the best alternative is, of course, we reflexly tend to take out the epidural needle out of the catheter. So it's not, the better technique would be to let it be there. And since the mother is already in pain, give her a low dose of maybe an intrathecal opioid with the low dose of intrathecal drug, the local anesthetic, something less than 2 milligram of bupivacaine, and then come out. And maybe, once your mother has good pain relief and she's now better in a condition to give you better position and cooperate with you for the epidural, we can put an epidural. The other technique that is recommended, of course, in setups where there is adherence to good infection control practices and 1:1 monitoring, is to leave a spinal catheter at the place of puncture. So that for the next 48 to 72 hours, so there is fibrosis. You need to label it, knot it, and be very careful. You can dose with smaller aliquots for spinal analgesia, but it has to have excellent monitoring and careful vigilance to infection control practices. So this is what I have to say. I think PDPH, we still have the gold standard is still epidural blood patches. All the blocks are temporary, they're just bridges. Maybe, they might work, they might not, but they usually, the effect wears off very soon.
Thank you, ma'am.
Dr. Hemant.
Ma'am, Dr. Tejke call, sir. Ma'am, please go ahead, ma'am.
Sir, please, Sachi.
No, ma'am, please.
So, Dr. Hemant, can you just highlight what are the recommendations for the placement of the epidural patch in the cases of HIV patients? Dr. Hemant,
Hello.
he left, I think.
Yes, ma'am. I'll have to look into that, ma'am. I'm not sure about it.
There is no clarity, but still, can you find out some guidelines regarding giving epidural blood patch in HIV patients?
I'll surely search for it, ma'am. If I
Yeah.
find anything, I'll share it with you, ma'am. Sorry, ma'am.
Dr. Tejke call, sir. Please, you want to say something, please, sir. Call, sir.
It's a very, very interesting and very nice topic of obstetric anesthesia. All the three speakers have done an excellent job. But what has baffled me is that in spite of all the good things, we talk about pain relief in labor. Why is it that we don't have 100% obstetric patients getting these pain relief? What are the reasons that we do not have? I am sure that if you take whole of the country into account, this is a point to ponder. What are the factors that we are unable to, or the patients are not willing to accept the pain relief services? Is it that multiple punctures? Is it? I know it should not be more than 15 to 20% of the patients in the whole of the country have got. 80% of the pregnant patients still do not use this. What are the factors? What are the reasons? We need to ponder about that. In my opinion, the biggest one of, there are multiple. We need to ponder about that. That is my question. That just talking about it, and even you see, my practice, I am in practice for 40 years in anesthesia. I still see that people do not have pain relief in labor. in my opinion, the biggest obstacle is the previous experience of the patients of multiple pricks and the post-cesarean backache after lumbar puncture. I think these are maybe simple and but need to be looked into. Another question was to Dr. Kirti that she said that epidural is the method of choice anesthesia for PIH patients. Why did she select epidural from subdural? Only because of PDPH or anything else? Thank you. Thank you for, sorry for my intervention, but this just came to my mind that I wanted to the people who are at the helm of affairs to ponder over it. Thank you.
Thank you so much, sir. I think you very rightly pointed out that it is previous experiences, but more often than not, sir, we need to have the obstetricians on board on these kind of webinars and also create more awareness programs where we can spare time out of our busy anesthesia schedules to sit in their antenatal clinics, be there with them to counsel the patients, take rounds in the antenatal ward. Only perhaps then we'll be able to increase the uptake of labor epidurals. There are still myths and in the minds of not only patients but also in the minds of obstetricians. So that is something which needs to be taken care of. Dr. Kirti, would you like to answer sir's second question?
Ma'am, CSC would be the choice, along with epidural catheter being placed with low dose spinal anesthesia.
But what is the, if you were to be given a choice between a single shot spinal versus an epidural or a CSC, in a cesarean section for a patient with preeclampsia, whose
Ma'am,
platelet counts are still okay, and they, of course, you say, as you said very rightly, they have to be above 70,000. What would you choose and why?
Ma'am, if there's an urgency, I would definitely go for a single shot spinal anesthesia.
We need to remember that single shot spinals are good enough until and unless you're expecting a prolonged surgery.
Yes, ma'am.
Most of the times they do better.
Thank you, ma'am.
So much.
I would also like to congratulate the winners of the youth conclave. All the three winners, they need to be congratulated.
Thank you very much, sir. Thank you very much, sir. Thank you very much for your kind words and pearls of wisdom, sir. Madam Dr. Shaili, ma'am, please.
Yeah.
For your last words, ma'am, before we conclude the session.
Actually, thank you so much, everyone, for joining in today. The topics were definitely excellent, and we take care of the OBS patient day in and out. So whatever you keep talking, whatever you keep discussing about OBS anesthesia, it's always less. So I think many more webinars will keep coming on this topic. So it was good to have the good discussion on OBS anesthesia.
Thank you very much, ma'am. And so wonderful to have all of you on board today, ma'am. Especially thanks to Dr. Tej K. Kaul, sir, Dr. Anju Garewal, ma'am, Dr. Sangeeta Khanna, ma'am, Dr. Kiran Preet, ma'am, Dr. Shaili Mittal, ma'am, and Dr. Indrani Hemant Kumar. We have Dr. Indrani Hemant Kumar as well with us, ma'am. Dr. Indrani, madam, please, can we have a few words from you, ma'am, please? I'm so sorry I missed to see you on board, ma'am. Please, few words from yourself.
Yeah, just a moment. One minute. Just a moment. Yeah. Thanks a lot, Vishal. Yeah, I just heard all the discussions and everything. And sir put in a very pertinent point that in spite of labor epidural being the gold standard, being that which can provide, almost near 100% pain relief, still, why this service is not being used by many patients?
I mean, as Dr. Anju also said, I would put obstetricians as number one reason. They themselves do not allow us to put it. That is number one. Number two, having worked in a very heavy obstetric unit at KEM Hospital, what I wanted to say was, I mean, the cesarean sections run like a workshop. Like one patient goes away, the next one is wheeled in, next one goes away, the next one is wheeled in. That's the kind of work in KEM Hospital. And what happens is, with so much of load in our residents and the staff members, we also find it difficult to dedicate complete all our time for labor epidural. So we do it sporadically. We do it because some units do allow this. But then, uh, if you ask us, I mean, it really, we have to bend backwards to go and do labor epidural. So that also, sir, could be one of the reason why we are not able to provide it in a government setup. However, I think in the private scenario in corporate hospitals, labor epidural has really taken over, has actually taken over very well. So I think this problem is only with the government kind of setup. That is my personal opinion.
Agree with you, ma'am. Absolutely. Now that I'm in
Agree,
my
agree
government
with you,
setup.
madam. Agree with you. Definitely agree with you. I agree. There are many factors. Thank you. Thank you.
Yes, sir. Wonderful, very wonderful webinar, sir. Really enjoyed it.
Thank you very much. Thank you very much for your blessings. Thank you very much.
Yeah.
And Dr. Naveen, sir, with your due permission, do we close the webinar, today's webinar? Ma'am, since I think Dr. Naveen sir is busy, so next in the line, ma'am, Dr. Anju Garewal, madam. So with your due permission, do we close the webinar, ma'am?
Sure, definitely. Yes.
Thank you very much. It was so wonderful
so
to be
much.
with in the
Thank
evening.
you. Thanks
Thank
for
you
your
so much, sir.
please.
Thank you,
Very
ma'am.
much.
Thank you for
Good
giving
night,
us the
everyone.
opportunity. Thank you.
Thank you. Good night, ma'am. Good night.
Long live RSA. Long live
Long live
RSA.
Long live
Long live
RSA.
RSA.
Long live RSACP. Long live.